to another educational webinar put on by Bolt. Very fortunate to have our speaker today to talk about the radial approach from sheath insertion to compression band. You may recognize him from his sommelier work on LinkedIn, or his Twitter activity, or him with his team on TikTok, the local news, CNN, or maybe you just know him from one of his many hundreds of articles in this world of neurosurgery and neuroendovascular treatments, and seen him present all over the world. So I am very pleased to welcome Dr. Pascal Jabbour from Thomas Jefferson University in Philadelphia here with us today. Before we get started, our usual rules of engagement. All participants will be on mute for the duration of the webinar. Questions may be asked through typing in the question and answer section that is located on the bottom of your screen. All questions will be asked at the end of the webinar, time permitting. Any specific questions regarding Bolt products can be obtained through visiting our website, bolt-usa.com, or emailing our marketing team at marketing@boltusa.com. Today we're trying something a little different than we've done in the past. We're going to actually utilize the polling questions. So please, if you're a healthcare professional, please participate and help give us some information as we go into the presentation. As always, from a regulatory approval, we have people from all over the world joining us. This program is intended for U.S. healthcare professionals. As we have attendees from various geographies around the world, some of the products or indications discussed may not be cleared or approved for use in all countries. Please refer to your local regulatory agencies or local Bolt representative for more details on this. So thank you, and we'll go ahead and get started. We're actually going to start with some opening polling questions. I will put these up now, and as I said, if you could please participate. I'll read through the questions. We have a couple up front here. So the question is, do you currently employ the radial first approach? Yes for all cases, yes but only angios and electives, only for angios, or no. The second question, what is the most common reason you hesitate to adopt the transradial approach? Was not trained on radial, there isn't enough education available to learn radial, I'm not familiar or comfortable with the anatomy, not convinced it is a safer approach, the lack of dedicated radial access devices. Question 3, what procedures do you feel least comfortable performing transradial? Flow diversion, intrasaccular, stroke, primary coiling, balloon-assisted coiling, stent-assisted coiling, or all of the above? I've already got three for all of the above. Question 4, what's your favorite catheter shape for transradial diagnostics? Berenstein, Simmons 2, Cobra, Simmons 3, Vert, VTK. Question 5, what is the most challenging transradial target vessel from the left? The right internal, left internal, right vert, left vert, all of the above, or none of the above. And what is the most challenging transradial target vessel from the left? So we got our right internal, right vert, left vert, all of the above, none of the above.
One should be right, one should be left.
Oh, correct. Well, yes, correct. The sixth one is from the left. Sorry, the first one is from the right.
Yeah.
My apologies. So we'll give this another 30 seconds to let people put their votes in. Got almost half the audience that has voted already. Last chance to put in your votes. And we will end the polling now so we can see how we answer. So Looks like Dr. Jabbour, you got your work cut out. About half of the audience is not radial first, so we'll see if you got them convinced by the end of this session. Main reason was not trained on radial. I think that's a pretty common theme that we've heard, with lack of dedicated devices being not too far behind. What procedure do you feel least comfortable performing transradial? All of the above, which makes sense with the number of people that are currently not transradial. Favorite catheter shape? Simmons 2 by a long shot, which I think you'll be getting into what you like to do with that in your talk. Left vert as the most challenging target vessel, and right vert as the most challenging from the left side. So that's great. Thanks everyone for participating. We're going to have another set of questions at the end of the talk, so please stay tuned all the way through. I'm going to stop sharing this. I will stop sharing my screen and hand it over to you, Dr. Jabbour.
All right. Okay, can you see the slide?
Yes, can see it.
All right, so thank you for having me. It's a great pleasure to be talking about transradial. We're going to be talking about every step of the transradial approach and how to switch your practice. Those are my disclosures. So this is one of the initial publications on transradial approach for coronary angiography, and this was a pioneer, Dr. Campeau, who's from Canada, was a pioneer in transradial approach for coronary angiography, and he published this paper in 1989, and this was the first series published about transradial. And in his paper, the conclusion was that the radial artery approach can be free of significant complication because of blood supply to the hand is provided in the majority of the patients by two large-sized arteries, and this is very important. And then he would say that because of almost total absence of ischemic damage to the hand or disability, in spite of a high incidence of occlusion following cannulation of radial artery for monitoring in the ICU, this is why also he would prefer transradial. So, as you know, the palmar arch is very rich in anastomosis between the ulnar and the radial territory. That's why having an ischemic hand is really case reportable. And I'm talking about a procedure here. I'm not talking about sick patients in the ICU with A-lines that stay there for 2 weeks or more. The shift from transfemoral to transradial has happened initially in cardiology because of not only reduction in access site complication, but decrease in length of stay, reduced hospital cost, and improved patient satisfaction. So both in Japan and Europe, the use of transradial has exceeded 80%, while in the US it's still 40%. Here I'm talking about cardiology. There are multiple large trials that show that not just it decreases access site morbidity, but it decreases morbidity in general and mortality also. As you know, the cardiologists, whenever they have a trial, they can enroll quickly a lot of patients because of the incidence of cardiac disease. In neuroendovascular, we struggle because of the low incidence of whatever disease we treat, but for cardiologists, every trial has thousands of patients. There are two major trials that look into that, the Radial and the Rifle, and both they showed decreased mortality and morbidity. Following that, there are 3 of the largest societies of interventional cardiology in Europe that issued a joint guideline recommending to use the transradial approach over the transfemoral approach for cardiac procedures. So why not in neuro? There is an overall hesitance in that, and that's normal, and I can understand that. First, because none of us were trained in transradial. We all trained transfemoral, and there is a perceived difficulty in navigating the vessels through the transradial approach, which is true, but you know, there's a learning curve, and there are some catheters to use. We're going to talk about all that. There is a learning curve, and we see that there's around 16% improvement in the procedural efficiency with transradial approach. This is one of the earliest publications from Korea from 2010, when they looked at transradial cerebral angiography. And they were able to successfully catheterize the radial artery in more than 99% of the time. The planned vessel of interest was successfully catheterized in 98% of the time in the mean duration of 28 minutes. In 2 cases, they had to convert the left internal, they were mainly left internal carotid arteries. One, there was a crossover to transfemoral. The other one, they just did the left common instead of the left internal. They didn't have any major complications, no radial artery occlusion, a minor complication 6%, and delayed, and then not delayed, radial artery spasm in 8 of the patients. Cost-benefit in the cardiology literature, there was a systemic review that showed that there is a cost-benefit, and it would reduce the hospital cost. A net hospital cost saving of $275 per patient using radial instead of femoral for coronary angiography. And the large cost saving was driven mainly by the complications, because as you know, complications cost money too. There's a big Cochrane literature review, around 30,000 patients that confirmed in the cardiology literature that there's a decreased morbidity in the transradial. In 2016, this was one of the first publications about transradial. We published that, and instead of thinking outside the box, thinking outside the groin, where we looked at cases where we couldn't access transfemoral, and we looked to see what access we had. And a lot of them were transradial, some of them were direct carotid cut down. But at that time, we used to do transradial whenever the arch is difficult or whenever we have trouble accessing the groin because of any problem with the femoral arteries. Then later on, we started seeing, patients in clinic, and a lot of my patients that have had coronary angiography, I would tell them we're going to do an angiogram, and they'll say, you're going through the arm, right? And I would say, well, no, we go through the femoral. And they would ask me why my cardiologist went through the radial. More and more, we started thinking, why not going transradial? And we started exploring that. And this is one of the initial papers we published in stroke. By the time when we published this, it was the largest series of transradial, 223 patients between diagnostic angiography and procedures. We looked at patient satisfaction. Also, this was one of the first papers that talked about patient satisfaction, where we sent a questionnaire to patients who had already a transfemoral approach, and we asked them to compare the transradial they just had with the previous transfemoral. We also noticed that for diagnostic angiogram, the mean procedure time was shorter in transradial than transfemoral. This is the patient satisfaction. Those are the questions we asked. And then, as you see here, all across, they were all favoring transradial, less complication, less recovery time. Would they choose the radial for the next procedure? All of them said yes. And then the mean stay for diagnostic angiogram was 5.5 hours in PACU for femoral and 1.5 hours for transradial before going home after a diagnostic angiogram. Not only the transradial approach carries lower risk and high patient satisfaction, but just by itself, the transfemoral approach, this is a paper that we just published it about access site complication in transfemoral approach for neuroendovascular procedures. So as you see here, complications can be different things, can be pseudoaneurysm, fistula, retroperitoneal hematoma, occlusion with compartment syndrome. And in the literature, the incidence of complication in transfemoral is in randomized controlled trials is 5.1%. So what should we do to be able to adopt a new technology in general if you're thinking about switching your practice? So the team needs to follow a protocol. We shouldn't be reinventing the wheel. That's very important. We should make it really easy on our team. Whoever is asking for a change needs really to invest and time in education. Like, I can't go one day and tell my team, oh, I want to start doing transradial, and then disappear and accept them. to do everything and expect them to prep the patient and position the patient the way I want. So this is a work in progress. As I said, it won't go autopilot from the beginning, but it will after that. Very important to communicate with colleagues in the country that are more experienced. When I first started, I called some colleagues that were more experienced than me in transradial. I started asking them questions and acknowledging your failures when you first start to be able to improve. Very important to give positive reinforcement to your team because you're asking them a lot on top of being busy clinically to start change techniques. In my opinion, you need to do 50 to 100 consecutive cases to feel comfortable. At the beginning, everyone will hate you. I'm going to tell you, I've been through that. The techs, the fellows, the nurses, everyone will hate you. But the PACU and the NICU nurses will love you because the PACU nurses, they don't have to babysit patients for 4 or 5 hours anymore. And they don't have to check groans, and the NICU nurses the same. Patients and families will love you, and then after you figure out protocols, positioning, catheters, everyone will be on board, and it will make sense. At the beginning, when some of the team would complain, I would ask them one question, and I would always have the same answer. I would say, if you have to have an angiogram, would you want me to go femoral or radial? And even the people complaining would say, oh no, I want you to go radial. So what do you need to figure out first? You need to figure out simple things. You need to figure out positioning, sheath, catheters, anesthesia, cases not to do, complication management, and convince the administrators that it makes sense financially, because this is always important. This is how they're going to come to you and say, well, okay, you're switching technique. How much are you saving money for hospital administrators? So, well, it saves money, definitely. We saw from the cardiology literature that it is saving money. Closure device, if you use an angioseal or MINX or whatever, the radial band is really very not expensive, cheap. So this is one expense here. Time in PACU, this is all paying nurses to stay with patients. So 1 hour versus 4 hours. Wasting the time to apply pressure, a lot of times you need to apply pressure at the ground, so you're losing members of the team to apply pressure. Cost of a CAT scan abdomen pelvis, and we have a very low threshold whenever we do a case. If there's any drop in the blood pressure or any increased heart rate or any back pain, we right away order a CAT scan abdomen pelvis to rule out a retroperitoneal hematoma. We send serial H&Hs, we get vascular consults, the cost of complications, cost of DVT when you have a delayed ambulation, and return visits to the emergency room, really. Whenever someone complains about the groin, we ask them to go to the emergency room right away. So let's start with the setup. It's very important not to be messy. And this, you do it by having the radial board and by elevating the arm. You don't have to have an arm in abduction, and you don't have to have a bridging catheters from the abducted arm all the way to the patient, because this is gonna cause a lot of dripping of blood, and this will be like the team won't like it. So as you see here, and what we did is we built up a platform, and at the end it should look like this: wrist and groin, all at the same level. As you see here, the arm is adducted to the side of the patient, and we don't have any bridging catheters. This is how it's going to look like. So at the beginning, we're going to give, once we put the sheath in, we give a cocktail of, for spasm, of Cardine, 3 to 5 milligrams, Nitro, 200 milligrams, heparin 2000 units. The catheter of choice for diagnostic is the SIM2 Penumbra, 120 or 130, it depends. If you're inserting the catheter into another guide catheter that you're going to use to avoid exchange, at that time you need a longer tip because you need to use the tip, so you use 130. You can use the Terumo SIM2, but the problem is all those Terumo SIM2 are 100 centimeters. The Cook SIM2 is very stiff. I do not recommend to use it. And sometimes I use the SIM3 if I want to get to the left verb. Now, the majority of my cases are done procedures. I'm talking 6 French sheath, and then you go whatever you want. If you use a Sophia, a Navian, a Benchmark, a 6 Envoy, whatever you want, you do that. If you want support, mainly, for example, in all my stroke cases, at that time you're going to use a sheathless, 6 French sheathless, long sheath. In this case, you have options of a 6 French Cook, shuttle sheath, an Infinity, the Ballast, or the Fubuki. All this will be sheathless. you would put your short sheath, then you'll exchange. Initially, I tried using the Neuron Max for transradial because of the coating causes a lot of spasm and doesn't advance well, at least in my hands, so I stopped using it. Shuttle sheath was really a good catheter to a long sheath. And then when I got introduced to the ballast, this became my favorite long sheath. I'll show you some cases. It really advances smoothly. It goes up, it climbs up to the left internal carotid, which is the most complicated or challenging one. So start with the sheath. Those are low profile sheath. At the beginning, I didn't have them. I used to use regular sheath, but then we started using the slender Turumo. The problem with those sheaths are that they are very flimsy and thin, and they can bend. They bend right away. What I use now is the Merit Prelude sheath. That's the one here. It's as thin as the other one, but it doesn't bend. But you need to keep it hydrated at all time. What's important with those sheaths is that there's no ledge between the sheath and the dilator, the introducer. With the slender and with the Prelude sheath. So you don't have to nick the skin, and it goes really easy, nicely. Ultrasound is your best friend. At the beginning, I didn't used to use it. Then I started using it, and my crossover rate decreased a lot. So regardless, you know, ultrasound is always there, and we use it especially for snuff box. So this is, as you see here, you go double puncture wall technique. You saw the on the ultrasound, went in with the needle and then inserted it. That's another higher view. You see your vessel here, your radial artery, then you're gonna see the needle going through when you do a double wall puncture, then you back it up slowly and then you insert the wire, the usual. This is the middle of the probe, the yellow thing, so you aim with the needle with it, and here it is, you see the needle going in the vessel in the middle of it. And then that's your sheath insertion. As you know, it's one step, no need to nick the skin with a knife. Here it is, it's in. Snuff box, we talk a lot about snuff box, that anatomical snuff box here. This is how it's going to look like. So one thing is you don't need to turn the table, as you see here, because you can abduct the arm real close to the patient, and you keep your table straight. Snuff box versus radial, we use snuff box for all diagnostics because when the patient will come back, we can use a virgin radial, and we can no chance of it being thrombosed. More and more, we've been doing more snuff box procedures. It depends on the patient, but a lot of time, definitely you can insert a 6 French sheath, short sheath there. And sometimes I'll show you we can insert a 6 French shuttle long sheath ballast through the snuff box. So it is a better anatomical neutral position for the patient, especially the patients that are awake getting a diagnostic angiogram. You don't have to turn the arm and tape it. You can keep it as anatomical position. And the snuff box is a distal branch. It's safer. The branch to the thumb had already taken off, so you don't have any risk in thrombosing the snuff box as high as more proximal. This is where anatomically it is. It's bordered by the extensor pollicis longus and the extensor pollicis brevis, and this is the snuff box artery. We have our big series of snuff box that's going to be published soon in operative neurosurgery, and this is those diagrams are from our paper. This is where it is, and this is where the sheath is. This is a quick overview of the snuff box. This is exactly where it is. And this is an old movie when I used to use the old technique. I didn't have the slender or the prelude. So here it is, under ultrasound, I'm sticking the artery and then inserting the wire, and then that's the cocktail, and then that's the sheath. That's the old sheath that I don't use anymore. Snuff box band, how are we gonna close the snuff box? You can use the regular radial, but this snuff box band from Merit will come exactly where it should be. As you see here, you inflate and then deflate a little bit, and then this is how it's gonna look like. In all the radial band techniques, you're gonna inflate, you're gonna keep the sheath there, pull it a little bit, I'll show you, and inflate until you don't have any more blood, then deflate until you see a little bit of bleeding, then inflate just enough to stop the bleeding. In this case, this technique will avoid overinflating and crushing the vessel, and this is associated with long-term radial artery occlusion. And then you're gonna use your SIM2 for your diagnostic. This is a radial band, the regular radial band, showing you the technique. So you're gonna, this is actually a baby that I used a radial approach for intraarterial chemo. This is what I use for a sheath, the introducer of the 4 French micropuncture kit. So you're gonna pull it back, then you're gonna inflate while you're pulling the sheath. As you see here, I'm pulling the sheath, I'm inflating, and then I'm gonna deflate until I see some bleeding, reflux. Deflated, then inflated again, and then here it is. So after so many angiograms, I stopped prepping the groin. For diagnostic, I don't prep the groin anymore, but I put the sheath like this, the drape like that. For procedure, for interventions, I still prep the groin just in case, but for diagnostic, I stopped. So after you have your access and everything, you're gonna go up and start catheterizing the vessel. It's very important to master how to shape the Simmons catheter. The Simmons catheter can be shaped in different way. This is shaping in the ascending. You can do it in the descending or ascending aorta. This one is shaped in the ascending aorta. As you see here, you're gonna go in with the Simmons, then you're gonna pull the wire, and then you're gonna give it a tug, a push, and then here it is, it's shaped. This is in the ascending aorta, the other one was the descending. So as you see here, I'm gonna put it again, I'm giving a push, and then it's gonna fall down, and here it is shaped. Sometimes you can shape it at the valve or in the heart. You have the wire bouncing up at the aortic valve. You need to give a lot of wire. You need to make sure you tell your anesthesiologist. They're going to see a lot of PVCs. And then that's the wire going up. And then you're going to follow with the sim, following the wire. And here it is shaped. Moving to another vessel. So you need to push to keep the sim to shape. You don't want to shape it for every catheterization. As you see here, I'm pushing. I was on the left. Now I pushed it, kept its shape. Again, pushed it, kept its shape. Now I'm moving to the right side. Pull out. You're gonna pull all the way and twist it sometimes if it doesn't pull. Here it is. I twist it, and then I'm pushing it, and this is how I kept its shape. Sometimes when you push, it can still go up, like here. Let's look again. I pulled, I pushed, it went up. So what you do is you twist it a little bit, and then you push, and then it will keep its shape. Another case of moving to another vessel. So I'm on the left, I'm pulling, then pushing, then doing it. Moving from right to left. You can puff on the right, you puff until it falls on the left side. This is if it's difficult, and here it is now, you're on the left side. Left vert. As you see here, you're in the left. And then either you would able to catheterize it if you have a long SIM3, or you need a really high wire. Take your wire high to be able to advance your SIM2 to the left vert. Left ICA, as you see here, you need to have the wire way up, and then it will follow. Lateral view of the left ICA, again high wire. Hooking the left, twisting and reducing. Look at here what's happening. So I twisted it, then I reduced it. So again, to be able to catheterize, you need to have the SIM2 in a stable position, and it needs to hug completely the angle between the arch and the proximal vessel. Let's look again here. So you hook the tip, then what you need to do, you need to twist. Now I'm going to stop here and tell you, you need to twist the right direction. So you need to twist really easily and carefully because if you twist the wrong direction, it will kick you out. So you twist to the right direction, and you'll have the shape. This is how it should look like. Now I'm gonna stop. This is not enough because you have it herniating all the way down. So if I'm gonna put my wire to go up, it's gonna herniate. So I need to pull back to hug this angle. And this is what I did. I pulled back, now it's in a stable position. Again, I'm reducing the loop here, look at it. Big loop, I need to hug it. Here it is, now I hug the angle. Now I'm able to push, because if I'm gonna push before, when it wasn't hugging the angle, it's gonna herniate down there. So left vert, one technique of doing the left vert without the wire is to go in, then once you're there, you're gonna twist the catheter and push in. And a lot of times, you catheterize proximally the left vert and you won't have the shape of the SIM2, the usual shape. It's going to be twisted, but you will have the tip in the left vert. This is another challenging left vert. Look at this angle, but again, as long as you have the wire really high, you'll be able to do it. Look here, it will have tendency to push down this direction in the arch, but it didn't because I have my wire all the way up. Berenstein, always keep the Berenstein in mind. The simple catheters sometimes can bail you out in difficult left catheterization. Sometimes all you need is just a Berenstein. As you see here, I'm able to catheterize the left, stable position, and here is my wire going up, and I'm able to do the procedure. So yeah, the SIM2 is your catheter of choice, but keep in mind other catheters, especially the left side, where you can use that. Bovine arch, when you have a bovine arch, that's the easiest one to go in transradial, but you don't need the SIM2 actually. Any catheter you use, you'll have your wire go in easily all the way directly up there. So you can use a SIM2, not the SIM2, I mean a Berenstein, or any wire will go in. So bovine arch is one of the nicest indication for transradial for the left side. Pulling out, once you're done, it's very important to make sure that your SIM2 is straight. If your SIM2 is shaped already and you pull out, it can go in shaped all the way and it can injure vessels. So as you see here, I made sure that it is straight before I pulled out. What about left radial? We always talk about right radial, right radial. Well, we have a series of left radial. Our manuscript is under review. And why? We wanted to see how many vessels and how easy it is to go from the left. And it's important because a lot of times when we're talking to the patients, they ask us, why not left? My right hand is the dominant hand. So if we're able to avoid the dominant hand, this is also a plus. Now, there is some anecdotal cardiology literature saying that if you go left radial, you minimize the risk of stroke. Because if you think about it, you're coming here and you're working in the descending aorta, so you're not working in the ascending aorta with the catheter, so you won't have a risk of intracranial embolization. So that's why we explored left radial. So left radial for snuff box, it's easy because you're gonna take the hand and put it on the belly of the patient and prep it. It's easier than regular radial. So you put the snuff box and you do it. So whenever you go left radial, your wire 90% of the time will go bounce on the aortic arch, on the aortic valve. I mean. So at that time, this is how in the majority of the times you're going to shape your SIM because your wire tends to go bounce on it. So as I showed you earlier, you give a lot of wire and then you shape your SIM2 when you go from the left. So going from the left it's easy to catheterize the right side, right vert or right internal. The most difficult vessel to catheterize when you go from the left is the left internal. We were able only in 15% of the cases to catheterize, this is a right vert from the left I'm showing you here. You give wire and then you advance and it tends to fall directly all the way to the right innominate. So left internal from the left, because of the acute angle, is difficult. So we were able to catheterize common all the time, but only in 10 to 15% of the time we were able to catheterize left internal from the left radial. Ulnar, yes, we would use ulnar. I would not recommend to use the ulnar in case a patient had already a radial procedure and came back for another procedure or follow-up and you diagnose occlusion of the radial artery. At that time, I would not use the ulnar. At that time, I would go to the left side if we use the right side, or I would go femoral, because this is your safety net. You don't want to go use ulnar and then occlude the ulnar, and then you'll have ischemic problem. At that time, you'll take away the benefit of going transradial. When do we go ulnar? Whenever we do a diagnostic and we think that the ulnar is much bigger than the radial, like here. So I did the ulnar procedure because the radial was small. After when the patient came for a procedure, I went ulnar, and that's the ulnar. You see the radial is smaller, the ulnar is bigger. We went and treated the aneurysm through the ulnar, and all you need to do is switch, just translate your radial bend to the ulnar, and you can do it. Here it is, here it is. What about intra-op angiograms? We switched to doing all our intra-op angiograms to transradial and snuff box. It makes more sense ergonomically in the room as compared to how we used to do it transfemoral. It's much better. The operator will stand on one side, and the tech will move the machine on the other side. Here it is. This is an intra-op angiogram after an aneurysm clipping. So it's more ergonomic. This is the paper we published about our initial experience of transradial for intra-op angiogram. This is a case intraoperatively where I did a left radial for a left common after an aneurysm that I clipped. What about spinal? Spinal agrams can be done transradial. Just something important, you need to use the 130 SIM2 because you need a long catheter. And if you have a lesion that's really low lumbar or higher sacral, and the patient is too long, at that time you may not be able to reach. That's why you need to use the 130. But for thoracic lesions, it can be done easily, and you can do it with the SIM2. You would go and catheterize the segmental progressively. This is a case of a type 1 dural arteriovenous fistula, spinal arteriovenous fistula, as you see here. We're going to catheterize the level, and you'll see the fistula. So here it is. You see the early draining vein and the fistula transradial. Procedures. So whenever we want to do a procedure, we exchange, if you want support, we exchange to a sheathless. Right now, what I've been using is the 088 ballast. There's an 80, 90, or 100. So I would put a 7 French sheath first, short sheath, to avoid nicking the skin. Then I would put my cocktail, then I would put my Terumo glide wire, and I exchange it to the long sheath. Here it is. I'm exchanging. This is one of the old movies. I'm using a Neuron Max, but I don't use Neuron Max anymore. This was a snuff box web procedure that I did the exchange. Then we published the transradial for newly FDA-approved devices. Practically, you're able to do transradial in all those. This paper, we talked about web, we talked about pulse rider, we talked about all the new devices. This is a case of a left-sided ACOM aneurysm with a pulse rider, so you need a lot of support. We were able to do it. That's the pulse rider getting deployed, and then the microcatheter going in, and then final result. Surpass, flow diverters, and even mainly surpass that needs a lot of support. Same thing. We're exchanging to the long sheath. Here it is. We go first with the SIM2 inside the sheath, then we slide in the sheath on top of it. This is the aneurysm we're treating. That's the CAT5, and we're unsheathing. This is the case of a web through the snuff box that we published as a technical note. Here it is. I have my SIM2. Then I'm advancing my long sheath on top of the SIM2. This is the catheterizing the aneurysm, and this is the web device being unsheathed in the aneurysm. And that's the detachment, and that's the final result. We published the transradial approach for treatment of brain aneurysms with flow diversion. This is a carotid cavernous fistula caused by a ruptured large cavernous aneurysm. transradial, that's the long sheath, that's the intermediate catheter, and we did a pipeline-assisted coiling of that. So as you see, I'm showing you cases that need support, because there's some false beliefs that if you have a case that needs a lot of support, you cannot do a transradial. Well, you can do any case, even if you need support. This is another case, a patient that had 10 years ago clipping of an ACOM aneurysm. That's a follow-up after the clipping. Then 10 years later, the patient comes in with a big recurrence in the area of the clip. Went transradial, that's the recurrence, and I did a flow diverter, a pipeline from A2 to A1, also transradial. You see the stasis of contrast. Strokes, that's the challenging part. I would not recommend to start with strokes as transradial, but slowly after you switch your elective procedure, you can move to stroke. You see even challenging cases for transfemoral. Here it is, going up, doing the procedure. This is a compilation of some stroke cases done transradial. This is a case of acute carotid stenting that we did. Another case of stroke, shaping the SIM2, going to the left side with an M1 occlusion. So see here how it's going to herniate. So that's what I'm talking about. It's going to herniate, and that's the challenge on the left side. But then you catheterize again, then you bring your wire higher, advance your SIM2 higher, and then it's going to follow. And you see here, the long sheath is following. Here it is, all the way up. Another case on the right side, M1 occlusion, same thing. This is a case where transfemoral was very tough. We went transradial, and look at this angle, and this is following. This is a M2, M3, so even distal mechanical thrombectomies are being done transradial. Another case, the left side, as you see here. Advancing. Look how tough is this arch, and we have, that's a ballast going all the way up, doing all those curves, climbing up all the way. This was a distal M3 occlusion that we opened. Another case. And sometimes your wire would go up directly. You take it, look at this loop, and here it is. It's following nicely all the way up. Even a loop like this, as you see, it's following all the way up. This is, we published our stroke and compared our stroke done transradial and transfemoral. We looked at 30 cases of stroke done transradial compared to 76 transfemoral. As you see here, the number of passes, the contrast dose, the fluoro time, procedure time, all non-significant difference. So in stroke cases, it makes sense, it makes sense not to start your TRA experience right away with stroke. I would recommend to figure out the nuts and the bolts in elective cases, because you cannot afford to have a high crossover rate in stroke, because you're going to be wasting time and worse outcome for the patient. So progressively you transition for strokes. Once you feel comfortable, you start doing strokes. At the beginning, I didn't do left-sided strokes. I did only right-sided stroke and of course posterior circulation. Then slowly I switched to left-sided also stroke. It makes sense to do transradial because all those are old patients with type 3 calcified arches. Usually those patients are on anticoagulation or antiplatelet, or they just got TPA, so high risk of complication in the groin. And usually the peripheral vascular disease would touch mainly the lower extremity arteries more than the upper extremities. That's why you'll have a higher chance in the upper extremities. You can set up the patient really right away and early mobilization. This is our experience with the ballast. It's under review. We looked at our cases where our conversion rate was practically zero. We didn't have, in those 32 cases, we didn't have to convert to transfemoral because the catheter wasn't following. So this is a compilation of cases. Quickly, as you see, difficult cases, you see the ballast going up really easily, climbing up nicely, smoothly. This is a left-sided case, left radial. You'll see how it's climbing up all the way to the right. You push it easily, it goes up. Here it is, another case. Another case on the right side, really going up. Same thing here. Another compilation of some cases. As you see here, this is really challenging when you have this acute angle. But if you look here, we're able to go up. Another case, also that's tortuous. As you see, it's climbing above the SIM2 real nicely. Here is the catheter going up. Another case, we're shaping the SIM2. Catheterizing, then you see the ballast sliding nicely, and this is where it performs nicely at the angle where it slides in instead of pushing down on the arch. Another tough case, look at this angle. Any other catheter would have herniated in the arch, and you see it's going all the way up. A left vert from the left side, same thing. For a basilar thrombosis. This case I showed you earlier. AVM embos, same thing. I'm going to go quickly through that. Coiling, same thing. IAC, I started doing babies with transradial. It depends on the age of the baby, but any baby above 3 years old, we're able to do it. This is if the baby is above 10 at that time, we're able to use a SIM, 4 French SIM. As you see here, I'm bringing my microcatheter to the ophthalmic artery. If the baby is less than 10 years old, at that time I go with the marathon from the wrist all the way up. That's a case of a baby for transradial approach. As you see here, I'm going only with the, this was actually a prowler, but either marathon or prowler. With only the microcatheter, you see the wire going up, and then the microcatheter following. And it makes a big difference transradial in babies because those babies are kept under Precedex for 6 hours so they won't bend their hip. And when you use the transradial, they are able to go home. This is a baby, an hour and a half later is walking and going home because I did the transradial approach. Another 2 babies. Anyway. And then we published our series of anti-arterial chemo in babies with the transradial approach. We had also a collaboration where all people in the country doing babies transradial. We published this in JNIS, and it has a good safety, profile. So my lecture won't be complete if I don't talk about complications. Are there any complications? Absolutely. Like in every technique, there are complications, but those complications as compared to complications in the femoral, transfemoral are much less. And in general, in anything you do, you need to be ready for complication management and plan B. So be always ready to deal with complications. First, as simple as advancing on the roadmap in the forearm. We learned this the hard way. Now I advance it all the time on the roadmap. And why is that? A lot of times you think that your glide wire is going nicely, but it's not. It's going through a small perforator in the muscle. So this is a case where we had an extract. Again, it looks scary. It's an extract, but it's really nothing to worry about. Extract in the arm, in the forearm, are nothing to worry about. All you need to do is put pressure for 5 minutes and watch the pulse ox on the finger, and that's it. It's done. This is after 5 minutes of pressure. Here it is, and you can do your case. Radial loops, very important to identify radial loops early. Every case with a radial loop will have an accessory radial coming from the tip. So if you go blindly, you can go in this accessory radial, and this is where you're going to have all the complications and the spasm. So that's the case here. We're going with a 27 microcatheter and the 14 wire through it, and then everything will follow. This is a radial loop typically, as you see here, going up with the radial. That's the radial loop. Then that's your accessory radial here. That's the brachial artery. So as you see here, if you go blindly, you're going to go in the accessory radial, and there's a small artery. So you need to go and do this. And how you're going to do the stern? Either with the 035 Terumo, you're able to do it, or you need to go with a 27 microcatheter and an 18 or 14 micro wire, and then follow everything with it. Here, wasn't able to do it with the Terumo, as you see here, another case. Flipping, and here it is. Flipped it, and then went up. And this is the case I showed you earlier, so I was able to get a 27 microcatheter, and then my long sheath will follow. You have to push a little bit, but then it will follow. So pause and look whenever you have unfamiliar anatomy. Sometimes you could do a diagnostic through the accessory radial, but you cannot do a procedure. This is how you're going to straighten it, as I said. Spasm, a lot of times you can have spasm, but if you give your prophylactic cocktail and if you listen to the patient, whenever the patient is in pain, it means spasm. You can either deepen anesthesia, you can give more calcium channel inhibitor, IA or IV. You can inflate a cuff, blood pressure cuff, inflated. This can cause ischemia and cause the vessel to dilate. You can inject nitro transcutaneous along the catheter. The most important thing, don't pull, don't try to pull really and force it, because you can have problems. Another case of a pseudoaneurysm. This is a 90-year-old patient that we treated with a stroke. Then she went to a rehab, then no one noticed that it was growing slowly. Once it gets to this size, you need to have surgery. But if we had caught it before, all you needed to do is apply a radial band. So this patient ended up having surgery for that. So pseudoaneurysm, it's mainly about the wrist band application technique, location of the inflation, amount of air you inflate with. If you recognize it early, the pseudoaneurysm, all you need to do is apply a band. I had a patient that had an inflammation. She was having pain. We gave her antibiotics, anti-inflammatory, and then she did well. Avoid the arch dance. This is the whirling dervish. Don't do this with your SIM2. If you do this with your SIM2, that's what's going to happen. So it means once you have the SIM2 up, don't start twisting it more than 1 time 360. This SIM2 broke, and we were able to retrieve it with a snare. This is because it got turned so many times. You can break the SIM2, or you can make a knot in the SIM2 if you're going to do the arch dance. I'm going to go quickly on this. What's that? You need to be able to recognize this unusual anatomy. This is arteria lusoria. The subclavian is takeoff, that's proximal here. At that time, you won't be able to shape your SIM2. It's going to slide in all the way in the descending aorta. This is arteria lusoria. Sometimes you're able to go in and then catheterize those vessels, but you're not able to do a procedure. That's why in the case of arteria lusoria, left subclavian is the best, left radial is the best option. Another challenging cases are the cases that have proximal common tortuosity. As you see here, the SIM2 won't work here. What we did is we came with a Berenstein to have support and straighten it. Especially left common loop, proximally, those are challenging cases. So here it is, we go up with the wire, it's going to straighten the vessel, and here it is, you're able to advance any catheter you want. What is this? This is a black screen. What I say, this is a black hole. This is the retroperitoneal space. That's the problem. It's a retroperitoneal space that we cannot see. We don't know what's happening as compared to that. So this is what I said earlier. You don't know what's happening there. After you do an angiogram or a procedure, you may have a retroperitoneal hematoma. You don't know. As here on the wrist, everything is in front of you. Gonna finish by the radial room of the future. A lot of improvement. Catheter transition zone is important. We need new catheters. We need to study the transition zone on catheters. We need to have a stiff proximal catheter to be able to really avoid herniation, but you need the distal part to be soft. And then you need to have a pre-shape, like a U-shape, to be able to hug this angle that I was talking about. So we still need a lot of those. There are a lot of room for improvement. More and more transradial is being used. This is a collaboration in the country with the STAR registry. We published that recently, 2,000 cases with the STAR registry, 5.2% crossover, 0.6% minor complication. This is our series of 760 cases that's under review. As you see here, the learning curve at procedure number 14, the fluoro time started decreasing. So, very important to master the position. Don't be messy. Left radial, keep it in mind. If it's a bovine arch, it's easy for the left side. If the wire goes up, just take it. As I showed you earlier, you don't have to shape the SIM2 each time. When the left is tough, you can use a Bernstein. If there's any pain, this is spasm. Be careful. Identify lusoria before the procedure if you have a CTA arch. Advance the wire on the roadmap. A radial loop, this is how you're going to deal with it, and avoid the arch dance. Cases not to do, lusoria, left-sided ICA in stroke plus minus early on, don't do it. Later on, if you feel comfortable, you are able to do it. The proximal loop is challenging. And as you know, this is a safe approach, less complication, better patient satisfaction, and it's a learning curve. Definitely you need to commit and invest in it. It's not going to come easily. And it should be used as primary approach, radial first. Whenever you adopt a new technique, there are always pluses and minuses. I'm going to leave you with that.
Alexa, turn on the AC.
Turning on AC.
Finally, a virtual assistant to help you navigate. Alexa, where's the nearest gas station?
Nearest gas station in 1.5 miles.
And to help maintain your vehicle. Alexa, order more brake pads.
Ordering new brake pads. Although maybe if you didn't stop so close to the car in front of
I left plenty of room.
you drive too aggressively.
If you were just quiet for 2 seconds, 2 seconds.
We'll talk to you literally the entire time you're driving.
I think you should have turned back there.